Okay, good afternoon, everyone. We have a full call for you today, so we are going ahead and get started. Welcome. My name is Lieutenant Commander Samantha Morgan, and I would like to welcome you to today's CDC Partner Update Call on COVID-19. This call serves as a way for CDC to share weekly updates on COVID-19 and our latest resources and guidance. Today's call will focus on CDC's guidance for slowing the spread at colleges and universities. First, we will hear from our COVID-19 Response Acting Chief Medical Officer, who will describe where we are with the response and give us insight into recent scientific findings on COVID-19. Then we will hear from two scientists from our COVID-19 task forces who were instrumental in developing the guidance focused on institutions of higher education. Afterwards, our speakers will answer questions we've received over the last week via email. Please note this call is intended for CDC partners involved in the response and is not intended for media. Should media who are listening have questions, we invite you to reach out to media@cdc.gov. This call will be recorded and later posted on CDC's COVID-19 website as well as on YouTube. All past partner calls can be found there, so please take some time to review and share prior recordings. We have covered topics such as vaccination planning, new tools for schools, and health and safety at polling places. If this is your first webinar with us, these weekly calls occur every Monday at 3 p.m. Eastern Standard Time. Please see the link on the slide to subscribe to our mailing list to receive future call invitations. I would also like to take this opportunity to remind all participants that the CDC website has our latest information and guidance. There are over 2,000 documents providing information and guidance for individuals, businesses, and the public on cdc.gov. In addition to the resources we'll highlight today, please check out the recent web additions. CDC added vaccine-specific content to our COVID-19 website. CDC's new resources include information on vaccination planning, how vaccine safety is being ensured, and frequently asked questions. I'd also like to highlight CDC's new COVID-19 Science Update page. This page shares peer-reviewed research findings for various COVID-19 related topics. The October 13 issue contains two updates about schools. The JAMA article titled Preventing and Responding to COVID-19 on College Campuses, and a second article reviewing school and university outbreaks and social distancing measures. Please check out the Science Update when you have a few minutes. There's always something interesting to learn there. Speaking of learning, the partner call team is always evolving and trying to make these updates more informative and run more smoothly. We've had some technical issues in the past, so we are changing up our Q&A process. Over the past week, we've been collecting your questions up front via email, and we will not be taking live questions during the Zoom. We have sorted and grouped your emailed questions, and the presenters are ready to share their answers in the last half hour of the call. As we did last week, we will have two short polls, one now and another at the end of the presentations to get feedback about the effectiveness of these calls. Please answer the poll now as we get started, and then again before we start the Q&A section. I am pleased to be joined today by three CDC experts on the COVID-19 response. Dr. Cliff McDonald, Acting Chief Medical Officer for the COVID-19 Emergency Response. Dr. Greta Massetti is the lead for the Joint Communications Cell for the United Government Response Mitigations and Risk Working Group, and the lead for CDC's Community Interventions in Critical Populations Task Force. Dr. Elisa Barrios is the lead for the School Field Unit, which is part of the State, Tribal, Local, and Territorial Support Task Force. Please note that today's call will include a couple of slides for Dr. McDonald's update, which is a change that we're trying out today. You will also see slides for Dr. Massetti's and Dr. Barrios' portion of the call. If you experience technical difficulties or otherwise would like to review today's call later, you can find the recording on the CDC webpage and CDC's YouTube channel. Now let's turn to Dr. McDonald for some updates.
Thank you, Lieutenant Commander Morgan, and welcome to everyone joining us today. My name is Dr. Cliff McDonald, and as mentioned, I'm the Acting Chief Medical Officer for CDC's COVID-19 response. Today, I'd like to provide just a brief update on the COVID response at CDC and some of the latest scientific developments and guidance. Globally, there have been almost 40 million cases and over 1,100,000 deaths as of October 19th. Here in the United States, there have been over 8 million confirmed and probable cases reported to CDC, and tragically over 218,000 deaths. This is more cases and deaths than contributed by any other country. India and Brazil are second and third in cases and deaths, India having more cases and Brazil having more deaths. Over the past 7 days, the average daily number of new diagnoses was 55,232, which is a 15% increase compared with the daily number during the prior 7-day period. Over the same 7-day period, the daily number of deaths was 700, which is a 2% increase compared with the daily number during the prior 7-day period. 75% of reporting jurisdictions and states are now, unfortunately, in upward trajectory. The degree of reported cases in this current phase of the pandemic will continue to vary by state. The daily numbers of both cases and deaths remain high, and achieving control nationally depends upon strong public health response, including social distancing, hand hygiene, masking in public, especially when you can't stay 6 feet apart from others, covering coughs and sneezes, avoiding touching your face, routine disinfection of high-touch surfaces, increasing ventilation, and of course, monitoring yourself and others for illness. We encourage you to visit CDC's COVID View for a weekly summary and interpretation of key indicators for the COVID-19 pandemic in the United States. Next slide. Today, I want to share some of what we've learned in the last few weeks from 4 reports from CDC published in the Morbidity and Mortality Weekly Report, also known as the MMWR. In the interest of time, I will only briefly touch on the high points of these reports, and I encourage you to visit cdc.gov to read the full report. Dr. Massetti will review the first 2 reports in greater detail later today, so I'll be brief. The first October 2nd MMWR is titled Recent Increase in COVID-19 Cases Among Adults Age 18 to 22 Years, United States, May 31st to September 5th, 2020. This report looks at the growth in cases in the fall for young adults across the U.S. From August to September, weekly cases in 18 to 22-year-olds increased by more than 50% nationally. The second, October 2nd MMWR is entitled Multiple COVID-19 Clusters on a University Campus, North Carolina, August 2020. In August 2020, a university in North Carolina opened campus, taking many steps to prevent spread. However, within 3 weeks, 670 cases were identified among students, faculty, and staff at the university. Next, I'll highlight findings from a third October 2nd MMWR titled Changing Age Distribution of the COVID-19 Pandemic, United States, May to August 2020. This report describes how cases in different age ranges are changing. During June, in southern regions of the country, the percent positive tests among younger adults, that is those from 20 to 29 years to 39 years of age, increased 4 to 15 days before rates of positive tests increased among older adults, those 6 years and older. This suggests that younger adults may have contributed to the spread of COVID-19 in the larger community. Finally, I'd like to highlight findings from an October 9th MMWR entitled Factors Influencing COVID-19 Exposure Risk Among Young Adults, Winnebago County, Wisconsin, March to July 2020. This report describes how Winnebago County, Wisconsin experienced an increase in COVID-19 cases, the largest of which was among young adults age 18 to 23 years. During interviews with young adults in Winnebago County, researchers gathered insights on attitudes and perceptions that influence the risk behaviors of the young adults in this area. They found misinformation, conflicting messages, opposing views regarding masks, social or peer pressure, perceived severity of disease outcome, and perceived responsibility to others, all cited as factors influencing behaviors such as wearing masks and attending social gatherings. To read more about these and other reports, follow the links on the screen. Before we move to today's speakers, I'd like to remind everyone that the 2020-2021 flu season is here. With rare exceptions, the CDC recommends annual flu vaccination for everyone 6 months of age or older. I encourage you all to get your yearly flu shot and encourage all partners on this call to support flu vaccination efforts within your organizations. Now is a great time to get the flu vaccine. With that, it is now my pleasure to hand you over to my colleagues, Dr. Greta Massetti and Dr. Lisa Barrios, to share information on slowing the spread of COVID-19 at our colleges and universities.
Good afternoon. This is Dr. Greta Massetti, and I'm pleased to be with all of you, sharing some information about this important topic. Today, I will cover some of our most recent data on COVID-19 among young people ages 18 to 24, including recent studies showing trends and outbreaks. I will also talk about our work with institutions of higher education and updates to our considerations for higher education. My colleague, Dr. Lisa Barrios, will talk about considerations for testing and outbreak response, as well as case investigation in institutions of higher education. I know that it can sometimes be a bit difficult to navigate CDC's website, given the sheer volume of information we've released since the start of the COVID-19 pandemic. It can also be difficult to read a web address off a slide. With that in mind, we've included suggested web search terms on the bottom of some slides that will help you quickly navigate to that particular resource being referenced on that slide. First, I want to share with you some information on trends in monthly COVID-19 case incidents by age group. This slide shows that the most cases overall, more than 1 million, were reported in July of this year. Cases declined in August and September. What you can see from this slide is month by month, the proportion of total cases that were represented by those older age groups. You can see those bars that are green, dark blue, and purple, the 45 and older, become smaller over time, meaning that fewer of cases were among those age groups. And you can see the growth in that 18 to 24-year-old age group, those yellow bars, increasing from March overall to September. This really suggests that this age group of young adults, who are oftentimes those who are attending institutions of higher education, constitutes a much greater share of reported cases than earlier in the year. Although young adults are reported to experience lower risks for severe disease and death from infection with SARS-CoV-2, they can experience severe disease themselves and can transmit infection to others at higher risk for severe illness. There is an urgent need to reduce the spread of COVID-19 among young adults. As Dr. McDonald mentioned, CDC recently released an MMWR showing an increase in COVID-19 cases reported among young adults ages 18 to 22 years old. In the United States, approximately 45% of persons in this age group, about half, were enrolled in colleges and universities last year. As these institutions reopened, opportunities for infections might increase. This is what we have seen. From August 2nd through September 5th of this year, new cases of COVID-19 among 18 to 22-year-olds rose by 55% nationally, as you can see in the charts shown by the solid black line. The increases were greatest in the Northeast, where new cases increased by 144%, and the Midwest, where new cases increased by 123%. During the same period, changes in testing volume for SARS-CoV-2 in this age group ranged from a small decline in the West to an increase in the Northeast. So although increases in reported cases were likely driven in part by an increase in COVID-19 testing, this is unlikely to be the sole reason for their increases in cases. In addition, the proportion of cases in this age group among non-Hispanic white persons increased from 1 in 3 to 3 in 4 during May 31st through September 5th. As colleges and universities resume operations, taking steps to prevent the spread of COVID-19 among young adults is critical. Approximately 71% of persons aged 18 to 22 years reside with a parent. Nearly 1/2 attend colleges and universities. Transmission by young adults is not limited to those who attend colleges and universities, but can occur throughout communities where young adults live, work, or socialize, and to other members of their households, some of whom might be at high risk for severe illness because of age or underlying medical conditions. The importance of addressing COVID-19 among young adults is further underscored by a study we published a week later, Transmission Dynamics by Age Group in COVID-19 Hotspot Counties, April to September 2020. In that study, from June 1 to July 31, 2020, 767 hotspot counties were detected, representing 63% of the US population. In these hotspots, the earliest increases in both number of cases and in positivity was among young adults aged 18 to 24 years. Increases in this age group appear to drive increases in other age groups. Dr. McDonald also reviewed an October MMWR that examined the rapid increase in COVID-19 cases and clusters at a university in North Carolina in August 2020. As shown on this graph, the university broadly opened campus for the first time since transitioning to primarily remote learning on August 3rd. Then, in-person classes began on August 10th. Consistent with CDC guidance, steps were taken to prevent transmission of SARS-CoV-2 on campus. During August 3rd through 25th, 670 laboratory-confirmed cases of COVID-19 were identified. Approximately 96% of these were among patients ages less than 22 years. On August 19th, all university classes transitioned to online, and additional mitigation efforts were implemented. Based on preliminary case investigations, student gatherings and congregate living settings, both on and off campus, likely contributed to the rapid spread of COVID-19 on campus. CDC is using emerging findings from studies like these, from ongoing monitoring and evaluation efforts at universities and colleges nationwide, and from conversations with educational leaders to update best practices, including optimal testing strategies for preventing SARS-CoV-2 transmission on campus and in adjacent communities. We have developed guidance and considerations. These include updated considerations for IHEs, which I will discuss in greater detail in a few moments, and considerations for monitoring and evaluation of mitigation strategies for IHEs, published just a month ago, and COVID-19 guidance for shared and congregate housing. In addition, we have held 12 listening sessions with key audiences to hear their concerns and perspectives and to help shape our future work. These include college students, organizations serving college university students, National Pan-Hellenic Conference, and the North American Interfraternity Conference, tribal colleges and universities, and historically Black colleges and universities. We also conduct outreach to associations and public and private universities, and we provide technical assistance upon request, including assistance on topics such as masking and physical distance, reopening, testing, case investigation, quarantine and isolation, sports, and travel during the holiday. For example, we recently worked closely with the American College Health Association on a webinar they hosted on wastewater surveillance in university settings. CDC scientists described what wastewater surveillance was, how it was conducted, and what it can and cannot tell us. In university settings, CDC scientists described what wastewater surveillance was, how it is conducted, and what it can and cannot tell us. Apologies for the repeat there, lost my place. Faculty from the University of South Carolina and from the University of Arizona described how they have implemented wastewater surveillance and what they have learned. This webinar was recorded and can be accessed on the ACHA website. Finally, we have worked with state and local health departments and IHEs to investigate specific outbreaks on campuses. While IHEs vary in their approaches to learning this fall, some are engaging in full in-person learning, while others online learning, and many a combination of both, we know that all IHEs face many challenges. The college lifestyle and experience is often not conducive to social distancing and other mitigation measures, such as masking and staying home when sick. Adherence challenges have been highlighted in recent news stories about the impact of college campus socializing and transmission. Uncertainty and fear are challenges in IHE environments as well. And unique to IHEs are housing and space challenges if someone becomes sick and requires isolation, or if someone is a close contact of a sick person and requires quarantine. This can be especially challenging with off-campus living, which is often beyond the institution's authority. Remote learning poses different but equally overwhelming challenges. Inequities can be furthered with differing access to technology and varying levels of stability in housing. For example, a recent news report discussed how some two-year colleges with campuses that are closed require students without reliable internet to drive to distant parking lots to watch classes on large screens from their cars. Faculty have varying levels of technical literacy, and many parents and students have expressed anger at paying high tuition rates for remote learning. Institutional loss of revenue from housing and food services, compromised academic and social opportunities for students, and impact on the local economy with fewer students supporting local businesses are also significant challenges. We are mindful of these challenges when trying to help colleges and universities address COVID-19. This month, CDC updated its consideration for IHEs. The updated considerations present categorization of risk from lowest to highest to account for learning settings, scheduling, types of activities, and use of mitigation strategies within IHEs. These include scenarios in full virtual, hybrid virtual in-person learning, and full in-person learning approaches. For example, lowest risk for COVID-19 is fully virtual. Some risk includes hybrid approaches with small classes, fully spaced, and mitigation measures. Medium risk includes hybrid approaches with larger in-person classes, still maintaining 6 feet of distance and mitigation measures. Higher risk includes in-person only learning with mitigation measures, and highest risk includes a lack of mitigation measures such as masks, social distance, hand washing, and sanitation. We have updated previous considerations in several key areas. These include planning and preparation to respond to when a student develops symptoms of, tests positive for, or has been exposed to COVID-19, including criteria for suspension of in-person learning, systems for monitoring spread and information sharing, and accessibility of information and services for students with disabilities or with limited English proficiency. The update also addresses maintaining healthy environments and healthy operations with more information about ventilation, engineering interventions like installing automatic doors, food service safety, and transit. We have new information on testing and contact tracing. We've provided coping and resilience recommendations and resources. We've updated considerations for when someone gets sick with the recommendation to not send sick students to distant homes because it could lead to community transmission. Finally, we have included additional considerations for accommodating students with disabilities. In summary, there have been concerning recent increases in reported cases among young adults aged 18 to 24 years old. CDC's updated considerations for institutions of higher education can help local health officials, school administrators, and communities prepare, plan, and respond to COVID-19. These considerations are meant to supplement, not replace, any state, tribal, local, or territorial health and safety laws, rules, and regulations with which schools must comply. Colleges can take action to prevent cases on campuses and broader spread within communities. It is critically important for students, faculty, and staff members at colleges and universities to remain vigilant and take steps to reduce the risk for SARS-CoV-2 transmission in these settings. Mitigation and preventive measures targeted to young adults, such as social media toolkits discussing the importance of mask wearing, social distancing, and hand hygiene, can likely reduce SARS-CoV-2 transmission among their contacts and communities. Institutions of higher education should support students and communities by taking action to promote healthy environments. Testing, contact tracing, and outbreak control, in coordination with local health departments, are also critical steps. My colleague, Dr. Lisa Barrios, with our state and local task force, will discuss these now.
Thank you, Dr. Massetti. That was a great overview. The work we're doing with IHEs is ongoing as we strive to understand what's happening and how to prevent and reduce the spread of COVID-19. IHEs are a critical partner in the prevention and control of a possible COVID-19 outbreak, but IHEs exist within larger communities. Outbreaks in local communities may introduce infection into the IHE, and IHEs should prepare for possible COVID-19 outbreaks in their local communities and keep in mind that community settings such as apartments, bars, and restaurants can pose a risk of transmission to students, faculty, and staff. What happens on campus also impacts the larger community. And a COVID-19 outbreak on campus not only makes it difficult for IHEs to carry out their academic mission, it also carries a risk of subsequent exposure for the surrounding community, including those who are at higher risk for complications, such as older populations and people with severe underlying medical conditions. Today, I'll focus on two specific ways IHEs can prepare to address and prevent outbreaks, namely contact tracing and testing. I'll begin by discussing how CDC is working with IHEs to learn the best ways to prevent and reduce transmission of SARS-CoV-2 on campus. CDC is working with IHEs to identify best practices and to share information through scientific publications and peer-to-peer sharing. IHEs are trying many different approaches to case identification. Some IHEs, for example, are promoting apps which determine proximity to other app users and provide notification when a user has been near someone who self-reports a positive COVID-19 test. App users can base considerations for testing on this information. However, few of these novel approaches have been scientifically evaluated. We're creating protocols and instruments to promote consistent data collection across IHEs in order to evaluate these approaches. When more institutions use the same instruments and methods, we know they're collecting similar types of data in the same way. Therefore, we're more likely to be comparing apples to apples across institutions, and we can feel more confident in drawing conclusions based on the results of their work. As more protocols and instruments are developed, we'll make them available to IHEs to use. CDC is also working with IHEs to learn lessons that can help improve all of our responses to COVID-19. For example, we're working with a few IHEs to observe mask use on campus and with others to understand who tests positive for SARS-CoV-2 during quarantine and when. The findings from this work will feed back into the guidance CDC develops and help ensure our guidance is based on the best available scientific data. We're interested in two types of data about IHEs: data about the strategies that schools are implementing to prevent or reduce the spread of COVID-19, and data that describe the cases that occur associated with IHEs. The College Crisis Initiative at Davidson College collects information on IHE reopening and mitigation strategy use for nearly all of the 3,000 plus 2- and 4-year public and private nonprofit IHEs in the United States. The map on your screen is from their dashboard, and it shows the variety of reopening approaches to the fall semester across the country. The pink dots are IHEs that are fully or primarily in person, about a quarter are primarily in person. The green dots are fully or primarily online, and about a third overall are primarily online. And the blue dots are using a hybrid approach. The College Crisis Initiative has a team of 30 students who search IHE websites for information like this. And we're working with them to expand the information collected on mitigation strategies like mask use requirements, the use of notification apps, and on-campus housing occupancy levels. As Dr. Massetti showed, CDC and health departments collect data on cases in regions, states, and counties. Finding data on cases and outbreaks associated with IHEs is more difficult. Some IHEs, though, release data on their cases through public-facing dashboards. These data are important for IHEs and their communities. Knowledge about the cases occurring in the IHE and the broader community should drive the mitigation strategies and testing strategies used. This new website, We Rate COVID Dashboards, is looking at these web pages, 223 so far, and rating them on how easy they are to read, how frequently the data are updated, and the kinds of data presented. It also includes links to the dashboards they've rated. This allows IHEs to understand if their dashboards are communicating to their students, parents, faculty, and staff in an easily understandable and readily accessible format. If you're interested in creating or improving your own dashboard, this resource might be useful for ideas on improving readability and accessibility of your data. As we transition to talking about contact tracing and testing, it's important to point out that there are many actions IHEs can take to prepare for COVID-19. Policies and partnerships form the basis for all other actions. IHEs should establish policies and conduct hazard assessments to understand their risks and facilitate preventive measures. A comprehensive emergency operations plan, policies, and standard operating procedures can facilitate a swift response. Strong partnerships with local health departments are important for case identification, contact tracing, and testing strategies. And IHEs could designate a liaison or office to become familiar with local reporting requirements, laws, regulations, and guidance. For IHEs that have the capacity to take a more proactive role in case investigation and contact tracing, collaboration with the local health department is essential. IHEs should initiate formal agreements with the local health department as appropriate, and IHEs and health departments should work together to define roles, responsibilities, communication, and data requirements. I'd like to focus now on contact tracing. Contact tracing is the process of eliciting and identifying people who have been in close contact with an infected person, and then contacting those people, notifying them of exposure and advising them to quarantine and to monitor their health. Health departments have legal authority and responsibility for communicable disease investigation and contact tracing. These authorities are granted through legislation and regulation and lie with state, tribal, local, and territorial health departments. However, a pandemic is a special circumstance, and case investigation and contact tracing in response to COVID-19 transcends standard practice. IHEs can play an important role in encouraging students, faculty, and staff to cooperate with contact tracing efforts. Partnerships between health departments and IHEs can expand the reach and timeliness of case investigation and contact tracing. This, in turn, facilitates prompt isolation and quarantine of cases and contacts. Such partnerships also address the responsibility IHEs have for the health and safety of the learning environment, typical requirements to protect students, volunteers, parents, guardians, and caregivers whom they serve, and responsibilities for the health and safety of the workplace, with specific requirements to protect their employees and contractors. Updated contact tracing guidance for IHEs is available at the link on your screen. CDC also recently released updated guidance on testing, screening, and outbreak response for institutions of higher education, available at the link on this slide. The updated guidance describes the kinds of tests that can be used, such as RT-PCR tests and rapid antigen point-of-care tests, and provides guidance on when testing might be useful for diagnosis or screening purposes. CDC recommends that people who have been in close contact with someone who has COVID-19 be tested, even if they don't have symptoms of COVID-19. While waiting for test results, it's important to stay home to avoid spreading the disease. And close contacts who test negatives after a few days still need to quarantine for the full 14 days. At IHEs, testing of students, faculty, and staff is one component of a comprehensive strategy. It should be used in conjunction with promoting behaviors that reduce spread, maintaining healthy environments, maintaining healthy operations, and preparing for when someone gets sick. The guidance also includes signs and symptoms, as well as guidance on testing asymptomatic individuals with a known or suspected exposure to someone with COVID-19. New information in the updated guidance includes considerations for expanded and widespread testing. Expanded testing includes testing those who might have been in close proximity to an individual confirmed to have COVID-19, whereas widespread screening testing includes individuals who have been potentially exposed at some point. A tiered risk-based approach to testing in the context of an outbreak starts with those with known close contact or exposure to a person with confirmed COVID-19 for a cumulative total of 15 minutes or more over any 24-hour period within the time from 2 days before the person with COVID-19 became symptomatic or received a positive test until the time that person is isolated. In a college setting, this might be operationalized as also including roommates, those who share a common bathroom, teammates, and people who attended the same gatherings, such as off-campus parties, where social distancing was not strictly adhered to with one or more individuals with COVID-19. The second highest tier for testing in an outbreak situation addresses those in the same vicinity as an individual with COVID-19 with at least 6 feet distance between individuals at all times. For example, this could mean students in the same residence hall, but who do not share a room or bathroom. The third highest tier includes those who have spent time in a common space, like common rooms and libraries, but not at the same time as an individual who tested positive for COVID-19, but where short duration exposure to those with confirmed COVID-19 cannot be definitively ruled out. The updated guidance includes examples of entry and periodic screening being used by some institutions of higher education and considerations regarding the likelihood of off-campus transmission. In particular, the importance of communicating frequently to students, faculty, and staff about the risks associated with off-campus settings and the potential impact on the IHE's ability to function. In summary, it's important for IHEs to plan their teams, partnerships, policies, and strategies for slowing the spread of COVID-19 in their facilities as people return partially and in full force. Students, faculty, and staff each play a role in preparing for the return to campus and being ready for the challenges of college life in COVID-19. And finally, trends need to be monitored and the community must respond with contact tracing, quarantining, and isolation as needed to keep people safe. Thank you.
Great, thank you very much. Thank you to Dr. McDonald, Dr. Massetti, and Dr. Barrios for sharing those updates. The next part of our call is our Q&A. But before we get started answering your questions, please answer the second poll and share your feedback. We received many great questions in advance, and we will get to those as we start this next half hour. So first, let's kick off with a couple of questions about flu and symptoms for Dr. McDonald. Dr. McDonald, should a person take the flu shot to help combat the coronavirus?
Thank you for that question. Flu shots are recommended for the vast majority of people to prevent the flu. Becoming sick with the flu may even reduce your resistance and contribute to becoming sicker if you do develop COVID-19. The flu shot does not combat the actual coronavirus, but receiving the flu vaccine will help you as an individual so you are less likely to become sick with either influenza or a dual infection of COVID-19 and influenza. It also will help all of us by reducing the number of serious flu infections that could result in hospitalizations, putting further stress on our healthcare system.
Thank you, Dr. McDonald. Another question for you. What are the initial symptoms of the coronavirus and when should a person go to the hospital? Since we are heading into cold and flu season, how can we better navigate the difference between common cold and COVID-19?
Well, the initial symptoms of COVID-19 are fever, loss of smell or taste, dry cough, aches and pains. Many of these symptoms overlap with the flu, except the loss of smell or taste is much more common with COVID-19. And right now is one of the symptoms that can best differentiate this illness from other respiratory illnesses. Unfortunately, serious lung involvement is much more common with COVID-19, and becoming severely short of breath is one important symptom to watch for to seek immediate medical attention. I would encourage anyone who thinks they might have COVID-19 to self-isolate, get help determining whether you need a test, where to get tested, and the seriousness of your illness. An important resource, in addition to talking with your medical provider, is CDC's coronavirus self-checker, the link to which we will provide in the chat box.
Great, thank you. Let's shift to some IHE-related questions. Dr. Barrios, Colby College and Cornell University have strict student behavior codes of conduct, mask wearing and gatherings, as well as testing protocols. What have we learned about these programs and how can we apply them on a broader basis?
Thanks for that question. Some universities do have strict behavior codes, and they're making strong efforts to enforce these codes around mitigation strategies specifically. We're working with the College Crisis Initiative to collect information on how many do. And we're also working with some IHEs to observe mask use on campus and off. And IHEs will be able to use this information to get a better understanding of who's wearing masks, where, and when. Our ability to control COVID-19 really does rely on everyone doing their part.
Okay, thank you, Dr. Barrios. Dr. Massetti, how useful is wastewater testing proving to be at schools and universities overseas and within the US as a proactive tool, or is it too early to tell?
Well, to date, CDC has only evaluated COVID-19 surveillance and wastewater at the community level, not at the level of individual facilities or institutional communities, including universities. So it is too early to tell right now. Nonetheless, the American College Health Association, as I mentioned earlier, they hosted this webinar on the topic of the potential role of wastewater surveillance in school campuses that featured our CDC team and university speakers, and that has some important information on implementation that might be of use. And CDC has developed wastewater implementation guidance documents for wastewater utilities, wastewater testing laboratories, and public health departments, which also includes considerations for wastewater surveillance at the facility level. And the guidance will be available soon from the CDC National Wastewater Surveillance System landing page, and I think the link should be in the chat box. So this information, universities and other institutions implement wastewater surveillance, and we're hoping to get better information about how effective these programs have been.
Perfect. Thank you, Dr. Massetti. We have another question for you. Part of the college experience is having a vital campus community that interacts with the surrounding community as well. What recommendations for college departments and student groups when it comes to inviting outside groups or members of the community to attend on-campus events and activities? Are there certain precautions that should be taken?
Sure, great question. Virtual-only events and activities pose the lowest risk for spreading COVID-19 on campus. Many IHEs have successfully stayed engaged with their surrounding communities during COVID-19 by moving lectures and other community events online and virtually. Prior to inviting outside groups or community members to participate in an event or an activity, it is important to consider the amount of COVID-19 spread in the local community or from communities where attendees may be traveling. If a decision is made to hold in-person campus events and activities, colleges and universities may reduce risk by encouraging attendees to wear masks and remain at least 6 feet apart as feasible, reducing the number of attendees or hosting an event in a larger space, preferably outdoors, may allow attendees to socially distance more easily. Additionally, posting signs in highly visible locations like in entrances or restrooms that promote social distances, the use of face coverings, and proper hand hygiene may also promote adherence to mitigation strategies.
Thank you, Dr. Massetti. Lots of questions for you. My daughter's roommate got COVID, and my daughter was not notified through the normal channels. The university said they followed guidelines by informing only faculty and students who attended the same class as the exposed persons, but did not include students sharing a dorm room or community shower in the contact tracing. Should universities consider having shared a shower facility with someone who was a positive exposure, and should it be part of the best practices to inform those who are exposed that way?
Yes, a good question. And as my colleague, Dr. Barrios mentioned, the guidance on contact tracing, especially in IHEs, that has now includes information on shared restrooms and other facilities. So part of that does address that. Generally, close contacts of individuals with known or suspected COVID-19 should be informed so they can take precautions using quarantine and testing if necessary. And as I believe Dr. Marios mentioned, a close contact is an individual who has been less than 6 feet for at least 15 minutes from a person with COVID-19, regardless of which communal space it was in, the restroom, the lunchroom, or classroom. So if a person in a communal shower facility was within 6 feet or more for more than 15 minutes at the same time with a person who is known to have or suspected of having COVID-19, then that close contact should be informed of their potential exposure.
Okay. So speaking of the shower specifically, do droplets travel farther? Do they linger longer in a high humidity environment? Does length of time in the shower make a difference in regard to whether the next person using the facility after an infected person is at risk? Should she wear a mask in the shower?
Great. So this is one of those areas where the questions that we have and the information we wish we had about COVID-19 is not yet at the place where we can answer all the questions, and we are rapidly trying to get better data. We're not aware of any scientific reports of the virus that causes COVID-19 spreading to people through showering. Research on droplet spread dynamics in high humidity environments is scarce. Therefore, we recommend that people maintain social distancing of 6 feet while showering. For instance, colleges might consider using every other shower stall if their shower stalls are closer than smaller than 6 feet. CDC also recommends that the shower space maintain good ventilation that brings in fresh air. We recommend only spending as much time as needed showering and avoiding prolonged time in communal shower spaces. We do not recommend wearing a mask while showering. Wet masks do not slow the spread as well as dry masks, and it can be difficult to breathe through a mask when it is wet. CDC recommends keeping your mask dry and wearing it once you finish showering.
Okay, thank you. Another question. With schools going online, hybrid classes, and social distancing, how do schools handle sports, clubs, and activities? Should students be allowed to continue to participate in competition and tournaments? And if so, where do we find guidelines on what is acceptable athletic protocols?
Sure. CDC advises individuals and institutions to pursue options to hold sporting events and participate in sports activities in ways that reduce the risk of transmission of COVID-19 to players, to families, to coaches, to communities. While we do not have guidance specific to team sports related to institutions of higher education, we have published considerations for youth sports, as well as information on how youth and adult athletes participating in sports can take steps to reduce their risk. These are available on our website and include staying home if an individual is sick, ensuring that players bring their own equipment like gloves and bats if possible, reducing physical closeness and keeping 6 feet of space between players when possible, wearing a mask, and also encouraging players to clean their hands before and after practices, games, and sharing equipment, and telling a coach or staff members if a person doesn't feel well. And then, of course, there's a variability in the level of risk and likelihood of close contact across different types of sports. So that's another piece for people to consider.
Thank you, Dr. Massetti. Another one, what steps can be taken by commuter students and those working off campus to reduce the risk of exposure to other students, faculty, and staff? How can colleges and universities develop messaging to communities placed at high risk about COVID-19? Are there any specific messages they can pass on to their student organizations?
Thank you for this question. So to help commuter students, colleges and universities can encourage students, faculty, and staff who use public transportation or ride sharing to use forms of transportation that minimize close contact with others, such as biking, walking, driving, or riding by car, either alone or with household members. They can also encourage students, faculty, and staff to stay home when appropriate, for example, when they're experiencing symptoms. And they can encourage students, faculty, and staff who use public transportation or ride sharing to commute during less busy times, to wear masks, practice social distancing, and clean or sanitize their hands as soon as possible after all travel, and to follow CDC and other guidance on how to protect themselves when using transportation. When developing messaging to communities placed at higher risk for COVID-19, IHEs should consider using communication methods that are accessible to all students, faculty, and staff, and other essential visitors, including parents or guardians. They should ensure materials can accommodate diverse audiences, such as people who speak languages other than English and people with disabilities. To help, CDC has developed communication resources and posted them on our website. And messaging to student organizations should encourage behaviors that we know reduce the spread of COVID-19, including staying home or self-isolating when appropriate, such as when students have been sick with COVID-19 symptoms, have tested positive, or have potentially been exposed. Frequently washing hands, covering coughs and sneezes, using masks in public settings whenever possible, and even when social distancing.
Thank you, Dr. Massetti. Now, what processes should schools have in place to respond to the mental and behavioral health needs of students?
I'm glad you asked. This is a really important topic. To respond to mental and behavioral health needs, school can communicate with faculty, staff, and students about mental health support services available at the IHE. Consider having an employee assistance program through which faculty and staff can get counseling. Consider posting signs for the National Distress Hotline, which is 1-800-985-5990, or texting Talk With Us. Ensuring continuity of mental health services, such as offering remote counseling through like a telemedicine type of model, and encouraging students, faculty, and staff to call 911 or the National Suicide Prevention Lifeline at 1-800-273-TALK, or the Lifeline Crisis Chat if they're feeling overwhelmed with emotions like sadness, depression, anxiety, or feel like wanting to harm themselves or others. Links are located in the chat right now.
Thank you, Dr. Massetti. Let's give you a break and we'll have a question for Dr. Barrios. What impacts, if any, have mitigation strategies had on indicators of academic achievement, like GPA, attendance, and career readiness?
Thanks. This is actually an area that CDC is actively investigating. CDC's Division of Adolescent and School Health is currently fielding a survey of adolescents ages 13 to 19, which will address these questions. And CDC is currently working to adapt the survey for college and university populations. We're sharing drafts with multiple IHEs right now, and we hope to partner with some to learn from their students' experiences.
Thank you, Dr. Barrios. Dr. Massetti, another one for you. What advice do you have for colleges and universities who want to return to pre-pandemic levels of in-person services, such as academic advising and admission interviews face-to-face with students in closed offices?
CDC encourages colleges and universities to adopt a layered mitigation approach to prevent the spread of SARS-CoV-2. Such an approach includes healthy behaviors such as social distancing, hand hygiene, and wearing masks. This is what we often refer to as the stacked layers of Swiss cheese approach, right? So no single mitigation strategy is completely foolproof, and it will no mitigation strategy will be implemented with 100% fidelity. But the idea is that when we layer those strategies together and stack them on top of each other, we can minimize the risk of transmission. Layered mitigation also includes promoting healthy environments and operations, such as like cleaning and disinfections, modification to physical spaces, and increased ventilation and staggered schedules. To reduce risk, IHEs can encourage telework for as many faculty and staff as possible, especially employees at higher risk for severe illness from COVID-19, replacing in-person meeting with video or teleconference calls whenever possible, providing student support services virtually. When possible, using flexible worker learning sites, flexible worker learning hours to help establish policies and practices for social distancing between people. It is important to ensure appropriate accommodations, modifications, and assistance provided for education to remain accessible for students with disabilities or those at higher risk of severe illness from COVID.
Okay, thank you, Dr. Massetti. Dr. Bears, let's shift our focus to testing. What role does pooled testing have in mitigation efforts on college campuses for students and for faculty? If the pooled test is positive, do you advise quarantining the pool while awaiting the retesting of the pooled specimens and then isolate the true positives? Many resources are going to do this, or do you wait until true positives are identified after retesting the pooled specimens, risking a day of more potential increased exposure on campus and in the community?
Thanks. Yeah, so pool testing can conserve limited laboratory resources, and it may reduce in it may result in a reduced testing turnaround time. But it's important to remember that test results are only reported individually, whether or not a pooled laboratory method was used. So the individual specimens in a pooled test that returns an initial positive result are immediately retested individually, and a pooled positive test result will never be reported out of the laboratory.
Okay, thank you. Another question for testing. We've chosen time strategy versus testing as recommended by our local health authority. In other words, we're using the time strategy of calling for quarantine when someone has potentially been exposed, does not meet any of our screening criteria, or actually contracts COVID versus using testing to determine when someone can return. This testing for our small school did not make logistical or financial sense. Do you agree with this approach?
Yeah, this approach can be effective as it follows established public health actions to reduce the spread of infectious disease. So it sounds like you're making an effort to isolate those who have tested positive and quarantine those who've been exposed to someone with COVID-19.
Thank you. Another question for you. Where can colleges, especially small colleges, get affordable and quick turnaround COVID testing?
Colleges should collaborate with their local health departments to identify ways to offer COVID-19 testing to their students, faculty, and staff. And individuals can also contact your local health department for information on where and when to receive COVID-19 testing.
Okay, thank you, Dr. Barrios. So what is the best response to the following questions that we might get from a parent? Roommate number 1 has symptoms, but roommate number 2 and number 3 do not have any. Should they all get tested or just the roommate with symptoms? Would all 3 need to quarantine or just one with symptoms? Should you get tested before quarantine to see if you need to quarantine? And is the length of quarantine still 14 days due to the incubation period 2 to 14 days, or is it now 10 days?
Complicated question. I'm going to try to break it down. So if roommate 1 has a fever, cough, or other symptoms, they might have COVID-19. If roommate 1 thinks that they might have been exposed to COVID-19, they should contact their healthcare provider. And if a test is requested or conducted by the healthcare provider and results in a positive finding, roommate 1 should isolate, and roommates 2 and 3 are now likely close contacts who should quarantine. Quarantine is used to keep someone who might have been exposed to COVID-19 away from others. So roommates 2 and 3 should quarantine in their living quarters or designated housing location, get tested as advised by their healthcare provider, practice mitigation strategies, and self-monitor for symptoms for 14 days, even if they initially test negative. Quarantine decisions don't rely on test results, and they shouldn't wait for test results to quarantine. A test won't tell you that you don't need to quarantine. It only indicates whether or not the virus was detectable by that test at that specific time. The length of quarantine is still going to be 14 days. Quarantine shouldn't be confused with isolation, which is reserved for those who are sick with COVID-19 or who tested positive without experiencing symptoms.
Thank you, Dr. Barrios. I'm going to take one last question for Dr. Massetti. Is there any science about allowing a student who is speaking to unmask in the classroom? If so, how far away from others should the student speak?
Students should not unmask in the classroom for purpose of speaking. Speaking, sneezing, coughing, and even singing can spread the virus. I mean, if you take a look at the MMWR about the choir practice spreading event, it has some relevant information. It's not the exact same thing, but one could see the aerosol generating of presenting, especially if you're speaking more loudly than typical. It could have similar results. On November 2nd, the CTC partner call will be discussing facility strategies for ventilation and cleaning in buildings, which may be of interest to this particular subject.
Well, thank you all. That is all the time we have for questions. Dr. McDonald, Dr. Massetti, and Dr. Barrios, do you have any closing remarks or additional thoughts you'd like to share?
Thank you for having us.
Yes, thank you for having us, and please remember to get your flu shot and encourage others to do the same.
Great. Well, thank you everyone for joining our call today. As a reminder, a recording will be posted on CDC's COVID-19 webpage as well as on YouTube. To subscribe to future updates and invitations, you can use the link on the slide. And thank you again. And please join us next time on Monday, October 26th, when our topic will be Healthy, Happy Holidays, Fall Travel and Gathering Guidance. Until next time, be well. Thank you.